You have to. Okay, everyone, we're going to get started. Thanks, everyone, for persisting. My name is Greg Cote. I'm from Oregon Health and Science University in Portland. I'm happy to be co-moderating this session with my partner here, and I'll have him introduce himself, and then we'll get started. In the interest of time, we have been asked to finish the session at 6:05, so we'll hold our speakers to 7 minutes, and we'll keep the questions to 2 to 3 minutes per abstract.
Sorry. Okay. Thank you so much. My name is Sishan Guo from the General Hospital, Chongqing General Hospital and Chongqing University from China. So I'm so glad to be here and discuss some interesting and hot topic about the pancreatic diseases. So let's start our registration. So the first speaker is Dr. Zhicheng Wu from Region Hospital Shanghai Jiaotong University School of Medicine, China. The topic of his talk is the pancreatic stem cells expand tumor burden and educate the tumor adjacent cellular cells to initiate carcinogenesis dependent on the KRAS and NF-κB CD106 positive feedback loop. Okay, there we go, please.
Good afternoon, everyone. Thanks for the chair. Sorry. This one. Okay. Yeah. Thank you for the chair, and I'm very glad to share with you our latest study of the pancreatic cancer stem cell and its role in the cancer initiation. Yeah. I previously described the stroma contribution in this paper, and the most related to today's topic is the identification for the first time, a very unique subpopulation in the pending lesion of PDAC. They share the parasite stem and the stroma feature, and they are very immunosuppressive and drives the resistance to PD-1 treatment. And we term these cells parasite stem cells with the very specific expression of CD106. According to the literature, CD106 has been described to be the mesenchymal marker, and it has a very important role in the cancer cell EMT process. And in the PDAC mouse model, researchers has been found that the EMT occurs as early as in the ADM or pending lesions. So we question whether there are two populations in PDAC expressing CD106 simultaneously. One is the mesenchymal originated, another one is the epithelial originated, and is it true in human PDAC? As a surgeon, we have more advantages to obtain high-quality surgical samples. As I show you here, I present you the HE staining of en-bloc hole-mounting staining from a very representative patient. As shown here, you can see the red dashed line indicated the tumor ductal cells in the tumor core. They are in very late stage. And the blue dashed line indicated the intermediate stage and also the tumor adjacent region. And the green dashed line indicated normal acinar cells. And these en-bloc hole-mounting staining show us the PDAC progression, and it reflects the cancer progression as most researchers found in the mouse models. Interestingly, we see that the CD106 expression in the tumor core are fibroblast and spindle-shaped, very similar to the alpha SMA positive cells. And on the other hand, the CD106 expression in the tumor adjacent region, they are much more like the ductal cells and similar to the CK19. We also verified the co-localization of CD106 and the CK19 in the pending lesion, which are in yellow, according to the spatial transcriptomic analysis. And the single-cell analysis also showed that the upregulation of CD106 is mostly among the epithelial cells and the fibroblasts. Our data showed that there are two populations express CD106 in PDAC in different region and with different signatures. We know that more than 80% human PDAC is triggered by KRAS mutation, and a KC mouse model initiated PDAC 100% by a KRAS G12D mutation. So we want to know if these CD106 positive CSCs carry KRAS mutation, and afterwards study their contribution to the tumor progression. For this purpose, we performed the KRAS G12D IHC staining, and we found there is a huge overlapping of KRAS G12D and CD106 in the tumor adjacent region. And in contrast, in the tumor core, G12D expression is low and rare. And this might suggest that in PDAC development or tumor expression, that the cells in the tumor core, the cancer is not predominantly driven by the cancer cells in the tumor core proliferation, but it is developed by the KRAS G12D positive cells in the tumor adjacent region. So we then question what is the incidence that trigger the KRAS mutation in the tumor adjacent region. For this purpose, we go back to the mouse model. This is a 3-month-old KC mouse, and we indeed find that CD106 and the CK19 double positive cells in the pending lesion. And from the Fox analysis, we show that CD106 all belongs to the EPICOM low subpopulation, and they are co-expressing CD24 and 44, which are the cancer stem cell markers. And then we generate the cell line, as shown here, CD100 positive CSCs. We term these cells cancer stem cells and with GFP tag in order to trace them. And then we take these cells and perform autotopic injections, and the result is quite interesting. It makes sense that all the injected cells express CK19 because they are epithelial cells. And however, very surprisingly, we found there is a certain region where it is a relatively early stage and pending lesion, and within this lesion, the cells are GFP negative, which means they are not developed by the injected cells, but induced by the transformed normal acinar cells from the host wild-type mice. And more interestingly, we verified that these cells are carrying G12D mutation. These preliminary data suggest that these CD106 positive cells might have the potential to trigger the KRAS mutation in the normal acinar cells and afterwards undergo the process of ADM, panning, and finally PDAC. So in order to understand this phenomenon, we go back to the literatures and summarize the sketch here. It is complicated in the human, in the cancer, as always, in terms of the tumor cells, immune cells, and the endothelial cells. As shown here, once the KRAS occurs, mutation occurs, the CD106 upregulated, and it is expressed to the surface of the tumor cells, and on the other hand, it is expressed in the paracrine manner that induce the macrophage M2 type polarization. And once the macrophage activated, it in return promote the CD106 production in CCL18 production, and in which the NF-kappa B pathway is also involved. Well, I'm not gonna go too deep to explain the endothelial cells today, but I will show you the preliminary data of correlating CD106 with the genes in the NF-kappa B and the sonic hedgehog pathway in our region cohort, and we are gonna do a more biomolecule experience afterwards to verify our presumption. And I will also show you that it is very interesting that we can find these CD106 positive cells as far as 5 centimeters away from the tumor border. And this is very challenging, because if it would be proved to be true, that they are the CSCs, we were facing the challenging of redefine the surgical margin as rather than follow the guideline nowadays. So here are some take-home messages. We found that the CD106 CSCs in pending lesions with EMT signatures, migration behavior, spontaneous malignant transformation potential that provide the answer why PDAC is such a deadly cancer of huge malignancy and metastasis. And our study might redefine the significance of surgical margin, that no cancer cells is not enough, and there should be no transformed or migrated CD106 positive CSCs in the remaining pancreas. Well, thanks for your attention, and I'm ready to take your questions.
Thank you so much for Dr. Wonderful talk. So because our limit is our time is limited, so no question time.
Right. Good.
So the next speaker is Dr. Rennie from Germany. So the topic of his talk is total pancreatectomy complex and hazardous nationwide analysis of 13,000 patients in Germany. Okay, there we go.
Good afternoon, everybody. It's a pleasure for me to talk to you about our study about total pancreatectomy analysis of 13,000 patients. To date, this is the largest study we have. And at first, I will thank to my co-workers, and I have no conflict of interest. Why are we discussing this topic? We are doing total pancreatectomies for several reasons. For instance, for histopathological reasons, for safety reasons, and for instance, if we do vascular procedures, we will avoid bleedings after surgery. Of course, if we use continuously blood glucose sensor measurement, the post-operative controlling of these patients is much easier today than in the past. And the other point is that we see more and more patients after neoadjuvant systemic therapies, and we can read in the literature then there are very good results from single center studies, even for total pancreatectomy. We're talking about these patients with a huge tumor mass in the pancreas head, and on the right side you can see the situs after the resection, and we put the prothesis for the hepatic artery and for the portal vein into the patient. Single center results. For example, I show you one single center study from Heidelberg. This is the largest single center study which ever published, with 1,500 patients, and you can see clearly there's a rise of total pancreatectomies over the last 20 years. And the Heidelberg guys built 4 categories: standard total pancreatectomy with venous resection, total pancreatectomy with other organ resections, and total pancreatectomy with arterial resection. As you can see, even the arterial resection show a clear increase over the time. And the Heidelberg group published very good results. Please focus to the mortality. 30-day mortality of all types was 3.5%, and especially for the most complex type 4, you can see it was 6.1%. The study. We analyzed now all total pancreatectomies in Germany over an 11-year period. We used routine data, and according to the 4 types of total pancreatectomy, according to Loos, to the Heidelberg group, we looked for several endpoints. For instance, mortality as the strongest endpoint. We analyzed 13,000 total pancreatectomy patients, and 600 hospitals did total pancreatectomies. The results. You can see we also saw an increase of the procedure total pancreatectomy. You can see we started in 2010 with 700 total pancreatectomies, and we finished in 2020 with 1,500 total pancreatectomies. And the diagnosis was mostly the orange bar malignant, but some people had benign diagnosis or chronic pancreatitis. Look to the mortality. For all types, we found a mortality of 23%, which is quite high. And for the most complex type 4, we found a mortality rate, in-hospital mortality rate of 35%. These are the complications. On the left side, you see the total pancreatectomy all. We found about 25% relaparotomy rate, 25% peritonitis rate, and about 15% postoperative bleeding rate. And if we look to blood transfusions, you can see, for instance, for the type 4 on the right side, almost more than 50% of the patients received more than 6 blood transfusions during the stay, and only a small part of under 20% received non-blood transfusions. This is a look to the caseload of the hospitals. We built 4 groups. The group with the largest caseload has 70 total pancreatectomies in the 11-year study period, and the lowest group, the blue one, had only 1 to 10 total pancreatectomies in the study period. And you can see the high volume group was only 35 hospitals, but they did about 5,000 total pancreatectomies. But you can see the low volume group, the blue bar, included over 300 hospitals, and they did only 1 to 10 total pancreatectomies. And you can see that has an influence to the mortality. In the low volume group, 1 to 10 total pancreatectomies, we saw 32% mortality rate for all types, and 57, please think about that, 57% mortality rate after type 4 resection. And with the increasing number, you can see the mortality rate drops down to 80.6% for all types and 28% for 4 types. Let me give you my conclusion. Almost all hospitals in Germany that do pancreatic surgery did also total pancreatectomies. Mortality in Germany after total pancreatectomy was quite high with 23% versus, remember the single center data from Heidelberg, 3.4%. But if you look in the literature, you can find some equal data, for instance, for the Netherlands. Heidelberg did more than 100 cases in the end of their study period to achieve these good results. The hospital group with the most cases in our study has a mortality rate of 80%, and with a low volume group for 32%. And the example of total pancreatectomy shows how important it is to centralize complex pancreatic surgery, which is now increasingly being used after neoadjuvant systemic therapy. How we handle these bad data in Germany, we will get from 2025 a new minimum quantity of 20 cases per year, and we will get structural requirements by law, and hopefully I can show you better results in the next years. Thank you very much for your attention.
Thank you so much for Dr. Revy. It's a very wonderful talk and excellent clinical work. Okay, the next speaker is from Taito Ito from Tohoku University Graduate School of Medicine. The topic of his talk is a molecular evolutionary model of early pancreatic cancer or large-scale multi-omics study. Okay, there you go, please.
Thank you, Chairman. I'm honored to have the opportunity to present our research findings today. All data are not published. Please don't share. Previous genetic analysis of advanced pancreatic cancer showed that PIK4 genetic alterations arise in stabilized manner. KRAS, CDKN2A, and TP53 mutations are present in high-grade binding. In contrast, somatic function loss, chromatosis, organ duplication, and the transition from the classical to basal-like phenotype are related events associated with invasion or metastasis. However, genetic analysis studies focusing on the early pancreatic cancer remain limited in scale and number. As a result, the molecular mechanism underlying these early phases are still unclear. In this presentation, I'll cover the key steps to establish a molecular evaluation model for RPDAC. We gathered 150 cases of stage 01A pancreatic cancer from 9 Japanese institutions. By means of microdissections, we separated a total of 233 regions, including isolated high-grade pines, I high-grade pines concurrent with invasive lesion, C high-grade, and invasive beta components. After assessing the quality of the nucleic acid and estimating the tumor purity through KRAS mutation analysis using digital PCR, we selected high quality samples for warm exome and moderate quality samples for target sampling sequencing. For trace control analysis, we investigated changes in gene expression during invasion and phenotypic shifts based on the Moffitt classification. Additionally, using FISH, we observed intratumor copy number dynamics, KRAS, and MYC. This slide shows the genomic landscape of our pancreatic cancer. Key alterations and synovials originate in I high-grade, and by C high-grade, the genetic profile is consistent with invasive cancer. The following is a list of the most common genetic alterations. KRAS mutations were found over 95% of cases. Alternation in CDKN2A, TP53, and SMART4 increases as I high-grade progresses to C high-grade. And loss of heterogeneity in KRAS was observed from I high-grade, while MYC application was detected in some cases starting from C high-grade. The total number of genetic alterations increased from I high-grade to C high-grade, and a comparable frequency between C high-grade and PDAC. Arithmetic alterations were present at half of the cases across all grades. We construct a molecular progression model of I high-grade using prognostic dependency model. Following KRAS missense mutations, alterations in arithmetic appear, followed by a deletion in TP53 copy number, and subsequent alteration in CDKN2A and SMART4. Notably, these alterations were found to occur earlier than previously reported. Arithmetic mutations are distributed without deviation in genomic regions, and truncated mutations are accounting for 65% of mutations. While previous studies have primarily focused on complete biallelic loss in copy number alterations, when considering one copy losses and shadow deletions, our findings indicate that arithmetic deletions are present about 30% of RPDAC cases, a frequency comparable to advanced pancreatic cancer. A correlation was identified between genetic alteration and protein expression. Alteration in one arithmetic allele was associated with reduced expression, where aberration with both alleles resulted in complete loss. In arithmetic pancreatic cancer, cases with arithmetic alteration demonstrated an increased propensity for recurrence. Arithmetic alteration and better phenotype were an independent risk factor for recurrence. The chromatin remodeling gene arithmetic is also involved in DNA repair, and its functional loss is known to trigger microsatellite instability. MSI evaluation was performed using long mononuclear repeat PCR and immunohistochemical staining for MMR proteins. MSI high was found in 31% of arithmetic cancers, regardless of arithmetic alterations. MSI high is rare in advanced pancreatic cancer, making it distinctive early stage feature. MMR protein expression was also unstable. This circle plot compares copy number variations across grades of early pancreatic cancer. Deletions and loss of major tumor suppressor genes such as TP53 and SMART4 begin in I high-grade and become more pronounced as the grade progresses. Mutant allele-specific inverse of KRAS starts accumulating in high-grade and reaches levels comparable to PDAC by C high-grade. Additionally, amplifications on oncogenes such as MYC and MET increase from C high-grade. We use fish to track KRAS and make copy numbers from high grade to invasion front. And this shows 2 copies, but fish revealed more within the epithelium. On the invasion front, these genes were further amplified and deployed. Cross-analysis of copy number variations showed that they increased with grade and TP53 alterations. Signature analysis of copy number based on cosmic method revealed an increase in CN30, indicating large-scale loss of heterogeneity, heterozygosity, and CN9 associated with chromosome instability, alongside progress, grade, and TP53 alterations. This slide illustrates the change in RNA expression revealed by transcriptome analysis. While a few genes were differentially expressed between C high grade and I high grade, many were between PDAC and C high grade. GSA of hallmark pathways showed changes in EMT, KRAS signaling, and MYC targets, becoming more pronounced with grade progression. These changes were particularly prominent at the transition to PDAC. This slide presents phenotypic change observed during grade progression. In the invasive component, bezel-like phenotype gene sets were enriched. RNA in situ hybridization analysis of GATA6 expression revealed a sequential decrease in expression from C high grade to budding regions. Notably, GATA6 expression was significantly reduced at the invasive front, highlighting dynamic expression changes within tumor. Additionally, GSA of hallmark pathways in the bezel-like phenotype showed enriched expression changes in gene sets associated with EMT, KRAS signaling, and so on. And this represents the evolution timeline from C high grade to invasion. We classified 2 cases into 2 groups based on phenotypic changes. The aggressive group, which underwent a transition from classical to bezel-like, and the consistent group, which retained classical. Analysis using a fast slow progressor gene set from Dr. Miyabayashi's pancreatic cancer organ mass duct transplantation model revealed upregulation of fast progressor genes in the aggressive and slow progressor genes in the consistent. Furthermore, RNA-seq data demonstrated correlation between the fast slow progressor gene sets and the PDAC molecular gradient, a framework for certifying PDAC prognosis. We calculated the evolution timeline, which indicates a difference approximately 1 year associated with phenotypic transitions. Here's a summary presenting the molecular evolution model of early pancreatic cancer. The onset of representative genetic alterations and phenotypic transitions occurred earlier than previously reported. Even in the early stages, a substantial proportion of cases exhibits the bezel-like phenotype, which is associated with poor prognosis. The transition into the bezel-like phenotype accelerates the progression to invasion. In I high grade, key suppressor gene alterations began to accumulate. KRAS imbalance and semaphore alterations are observed in I high grade, indicating earlier onset than previously reported. Arrhythmia alterations are frequently observed even at early stages, highlighting their potential as a variable molecular marker for early detection of pancreatic cancer. In C high grade, tumor suppressor gene alterations and KRAS specific imbalance are indistinguishable from those in invasive cancer, and oncogene amplification has begun. The evolutionary timeline demonstrated that the transition to bezel-like phenotype subsequent to invasion accelerate the invasion process. In conclusion, in high grade, major genetic alterations have already accumulated, and drastic genetic changes drive the progression to invasive cancer. High grade is a window of opportunity to prevent invasive progression, making the detection and eradication of high grade is a key factor in improving pancreatic cancer prognosis. We'd like to express our deepest gratitude to the collaborating researchers for providing early pancreatic cancer cases and offering their expert guidance throughout this study. Thank you for listening.
Great job. Again, in the interest of time, we'll skip questions. I encourage all of our speakers if they could stay at the end of the session. And then those of you are welcome to come up towards the podium and have one-to-one conversations at that point. I'm happy to introduce our next speaker, who's from Mass General Hospital in the U.S., Apostolos Agaitanidis. I hope I pronounced that correctly. He's going to speak about GWAS identifies genetic polymorphism at foot 2 to be associated with IPMNs.
All right. Thank you so much. Thank you for the podium. Thank you. I have no disclosures. So pancreatic IPMNs are papillary proliferations of mucin-producing epithelium causing cystic dilation of the pancreatic duct. They're classified into main duct, branch duct, and mixed types. The risk of malignancy is present in most IPMNs, and patients need to be followed with serially. The Fukuoka guidelines recommend various different characteristics, cytology, fluid studies, and imaging characteristics to distinguish between benign and malignant disease. The genetic risk factors are unknown largely. There are some associations described with genetic cancer syndromes, including FAP, Lynch syndrome, and Peutz-Jeghers. And invasive IPMNs have further been found to have abnormalities in the beta-catenin pathway, as well as patients with IPMNs have increased risk of extrapancreatic malignancies that further suggest a genetic link. Several studies have shown different copy number variations in patients with IPMNs and high-grade dysplasia or invasive disease, which are distinct from patients with pancreatic adenocarcinoma. Interestingly, several mutations that are found in pancreatic adenocarcinomas, such as P53, P16, and KRAS, have also been found in IPMNs. So the aim of our study is, since this likely represents a polygenic phenotype, as no specific locus has been found for all IPMNs, and so we aim to perform a genome-wide association study to identify genetic risk factors for the development of pancreatic IPMNs. We use the Mass General Biobank, which has prospectively enrolled 120,000 individuals in the Northeast. Those individuals were genotyped using Illumina's arrays, focusing on single nucleotide polymorphisms, or SNPs. After genotyping, there were a variety of different quality control methods to ensure good quality of the sample. The data was there imputed on the Michigan imputation server using the HG19 assembly of the genome. After imputation, we further did quality control to assess for cryptic relatedness, as well as population stratification, which was adjusted with a combination of principal component analysis, as well as our mixed model used for the association analysis. The phenotype of IPMN was determined through a comprehensive chart review of all genotyped individuals. A variety of keywords was used looking through the electronic medical records using IPMN, introductal, and papillary. And then we manually reviewed all charts to verify that the diagnosis of IPMN had been made. For the association analysis, we used the mixed linear model using the GCTA software, and the minor allele frequency was set at 5%. The significance threshold was a standard threshold used in all GWAS. And the results were then validated in an independent cohort. So overall, we had 68,931 individuals, of which 3.6% were diagnosed with an IPMN, either main duct, branch duct, or mixed. There were no major differences in terms of sex or smoking status or alcohol abuse. Obesity was slightly less prevalent in the IPMN group compared to controls. So these are our results viewed in a Manhattan plot. On the x-axis, we have the genomic coordinates, and its quote-unquote skyscraper represents a chromosome, and its dot represents a SNP. And the y-axis, we have the p-values for the association analysis. So this is the Manhattan plot. As you can see, the red line is the line of significance, and there is a locus chromosome 19, which is significantly associated with a phenotype of interest. This is a locus plot showing the SNPs kind of in purple and red color. They're significantly associated with a phenotype, and they correspond to the FUT2 gene. Those results were then validated in an independent cohort of 5,000 subjects, and this is a lead SNP that had the highest association with the phenotype. So what do we know about this SNP? It's a polymorphism that causes early termination of transcription due to replacement with a stop codon. And what do we know about the FUT2 gene? Is also known as galactoside 2 alpha L fucosyl-transferase 2, also known as the secretor gene in the Lewis antigen system. And interestingly, the non-secretor phenotype is specifically mediated by our SNP of interest. So the FUT2 and our SNP of interest are central in the regulation of CA and CA99 levels. There's studies, all sorts of GWAS studies that show associations between CA and CA99 levels and FUT2 loci, or specifically our SNP of interest, by several authors as listed in the slide. There's also associations between the SNP of interest and non-neoplastic pancreatic and biliary disease, including chronic pancreatitis, as well as primary sclerosing cholangitis. So overall, we identified a locus at FUT2 to be associated with the development of pancreatic IPMNs in a large US cohort. This is one of the first GWAS reported in patients with IPMNs. The SNP of interest that was a lead SNP in the study is central in the regulation of CEA and CA99 levels, and abnormal activity of FUT2 could be an early step in IPMN development and further guide diagnosis and treatment of this condition. Thank you so much.
Great job. Great job staying on time. We do have time for about one or two questions here. And I'll go ahead and ask the first, which is, could you speak to the proportion of patients with IPMN with this subtype, the FUT2, with that polymorphism versus controls or reference population?
Yeah, I have to go back in the data for that and specifically look for that. We kind of look at the entire genome. So yeah, it was something that I would have to go back and look at. I guess the odds ratios are really small in GWAS studies, so it could be like an additional 1 or 2% risk extra by having this SNP.
Right. So probably not something that we would necessarily use in the clinic to identify a higher risk patient for a cystic lesion.
It would have to be, yeah, way more SNPs identified for the phenotype before we can make that determination.
Great job. Thank you.
Thanks.
Okay, I'm happy to announce our next paper will be presented by Dr. Sen Yang from Peking Union Medical College in China. And this abstract was the winner of the best abstract in early detection of pancreatic cancer research. And this is generously funded and supported by the Kenner Family Research Fund. The paper is Cystic Fluid Microbiome and Metabolomic Profiling Implicate Microbial-Driven Lipid Metabolism Imbalance in the Carcinogenic Potential of Pancreatic Cystic Neoplasms.
Good afternoon. Oh, sorry, it's not my. Yeah.
We need Sen Yang paper. This is the wrong abstract up. Sen Yang. And could you just reset the timer for him, please? Thank you.
Okay. Good afternoon. It's my pleasure to present our researchers on comprehensive profiling of a microbiome, metabolome, and isonorm profiling of cystic fluids to reveal heterogeneity in pancreatic neoplasm and malignancy potential. Pancreatic neoplasms is increasingly common with a prevalence of 2 to 15% based on the imaging results, and some autopsy studies have reported up to 50%. And the incidence risk significantly with age, and the overall malignancy risk is a no between the 0.5 to 1.5% with annual progression of the 0.5%. But about 15% of the pancreatic adenocarcinoma are ranging from originates from mucinous cysts. Currently, surgical resection is the only curative option, but carries a high risk of complication despite technological advances. So we need early and precise diagnosis for high-risk PCNs is crucial. And PCNs contains many types, such as IPMN, MCNs, and SNs, and they have different malignancy potential, such as IPMN and MCNs can progress to the cancer, but SNs really do. And there are some key studies has reported the microbiome in cystic fluids of the pancreas cystic neoplasms, and several bacteria has been linked to this malignancy and with increased inflammation. And in our study, we have enrolled the 188 PCNS patients into our cohort and using the 3 technologies to detect the microbiome, metabolome, and adenoma. And this is the clinical characteristics of PCN cohorts. And for the and we characterize these cases into the 4 groups of PCNs, like cystic degeneration of the solid tumors, including SPNs, PDACs, and PNETs, and mucinous cystic lesions, including IPMNs and MCNs, and non-neoplastic cystic lesions like chronic pancreatitis and pancreatic cytocysts, and simple or lymphoephysioid cysts, and serous cystic lesions. But not all cystic fluids can be detected by the 16S and ITS sequences. The quality control rates varied among the 4 groups, and the CDSTs had the highest bacterial detections, and the non-cells had the highest fungal detections, but the mucinous PCNs has the lowest for the both. And bacterial detection, while 16S sequence exceeded fungi detection by ITS, and this can be avoided by AutoU count comprehensions. And alpha diversity referred to the bacterial species in the cystic fluids, and S cells exhibit significantly higher alpha diversity than M cells, indicating broader ecological diversity and a more stable microbiome community. And we can see the similarities at the higher taxonomical levels in CDST and MCLs or non-cells and to S cells, but get the finer taxonomical levels, MCLs can be distinguished by from the other 3 groups. And this reveals that MCLs has their unique ecological niches, metabolic functions, and immune characteristics. And the Sankey diagram has depicted the different distribution of bacteria in cystic fluids, and it can reveal that the lower abundance Staphylococcus and Streptococcus normally enriched in M cells. And but we have to acknowledge that IPMNs and MCNs have unique clinical and molecular features and not fully captured by the MCL grouping. So we have to focus on the 3 types of PCNs. And SCNs should higher bacteria alpha diversity than IPMNs and MCNs, but in PCOA analysis, we can observe the IPMs has unique features. And the second diagrams also notice that the Streptococcus dominates in IPMNs and Staphylococcus prevails in MCNs, and SCNs has the most unique general indicating greater microbiodiversity. And the difference analysis and the NAFC analysis further indicated these 2 key bacteria generals in the 2 types of the PCNs. And metabolic characteristics, we have identified 566 metabolites and with 447 significantly differing among 4 groups. And clustering reveals the distinct metabolic separations, particularly between M cells and S cells. And S cells were enriched in carbohydrates and the organical compounds, whereas M cell features usually lipid-rich metabolites. And this is their pathway enrichment. They share some common pathways and they also have a difference. And IPMs shows a differentiated metabolism characteristic with M-sense and S-sense by the clustering. And the pathway enrichment also shows IPMs focused on the energy consumption pathways. And we introduced pancreatic cancer metabolic data sets for further comprehensions with IPM and M-sense, and using the benign controls for the control. And we can see that PanDAC have the broader metabolic alterations to choose tumor-related metabolic reprogramming, and the similarity in dice conclusions show that IPMs share more metabolic pathway similarities with PanDAC than M-sense. That is aligned with the higher malignancy risk of IPMs compared to the M-sense. And ionic profiles always reflect the metabolic activities, and M cells and S cells exhibit no significant trace element difference except for the increase. But IPMs show the broader ionic diversity. It's indicated the active and unstable metabolism. And we aim to explore the connections between the key bacteria general and significant metabolites. So we used the 5 correlation method to find the significant metabolites. That is palmitic acids, which by 5 correlations. And this is the positively and negatively correlated substance with palmitic acid in IPM and cystic fluid. And previous studies have reported palmitic acid can introduce ER stress, oxidative stress, and cellular disruptions to promoting cancer. So we have the using the gene analysis of the PanDAC data sets, and can find that there are 14 pandemic acid metabolic enzymes upregulations. And the ER stress rich genes had the positive correlations with the metabolic enzymes. So there, or maybe the pandemic can drive the ER stress to promote cancer. So can get conclusions. We have to get a comprehensive analysis of the microbiome and metabolic and unknown profiles of the cystic fluids in pancreatic cancer. And essence example the more diverse and stable bacteria community compared to Mucinus PCN. And especially Streptococcus and Staphylococcus are key bacteria generally associated with IPMs and M-sense respectively. And there is a transition from carbohydrate anaerobic metabolism in essence towards to the lipid-focused metabolic pathway in IPMs and M-sense. And it's corresponding to the increased malignancy. And IPMs approaching the metabolic profiles observed in pancreas ductal adenocarcinoma. And IPMs shows a more dynamic and metabolically actively landscape compared to M-sense. And the palmitic acid driven ER stress maybe that promotes the malignant progression in IPMs. That's all for your think.
Okay, great job. We'll move on to our next speaker. I'm happy to introduce Dr. Abraham Levi from Cedars-Sinai Medical Center. Dr. Levi will be speaking about prognostic implications of chemotherapy and site-specific molecular landscape of lung-only and liver-only metastatic pancreatic adenocarcinoma.
Good evening. My name is Abraham Levy. I'm a part of the GI Oncology Research Group at Cedars-Sinai Cancer Center, and I'm honored to present to you our work on the prognostic implications of chemotherapy and the site-specific molecular landscape of pancreatic adenocarcinoma that has metastasized to either the liver only or the lung only. As most of you know, pancreatic cancer is a lethal diagnosis. In 2024, the American Cancer Society estimates that there'll be over 66,000 new cases with over 51,000 deaths. Pancreatic cancer is the third leading cause of cancer-related deaths in the US, with the lowest 5-year survival rate of 13% across all stages. And by 2040, pancreatic cancer is estimated to be the second leading cause of cancer-associated mortality. A big part of this lethality and what makes pancreatic cancer challenging to treat is that over 50% of patients have metastatic disease right at presentation. And while multi-agent cytotoxic regimens of systemic therapy consisting of gemcitabine paclitaxel, FOLFIRINOX, or NALIRIFOX remain the preferred treatment, these only have modest improvement, with the 5-year survival rate for metastatic pancreatic cancer being less than 5%. Common sites of metastatic spread for pancreatic cancer include the liver, the lung, the peritoneal, and of course the lymph nodes, with the liver being the most common, but the lung being fairly common as well. And interestingly, multiple investigations have reported on the impact of site of metastases on survival. Specifically, there seems to be a longer median overall survival for lung metastases relative to liver metastases in pancreatic cancer, but the genomic characteristics associated with PDAC that has metastasized to either the liver or the lung only are not well defined. Therefore, the aim of our study was to understand these survival differences and also the associated specific molecular features of metastatic PDAC that is isolated to either the liver only or the lung. And we did this by utilizing Prothera's real-world evidence database, which is a national database where patients across the United States were registered onto an IRB-approved protocol. Between the years of January 2012 and December 2022, 2,094 patients were enrolled onto this protocol, and patients provided NGS testing results as well as clinical outcome and variables were manually abstracted from chart searches. And from this group of 2,094 patients, we curated our analysis, or our total cohort of 831 patients, comprised of 142 patients that had lung-only disease and no liver lesions, and 689 patients that had liver disease and no lung lesions. And we further broke that down into a resectable cohort. This is a subset of patients with metastasis identified after a successful resection, and an advanced cohort. These are patients that had metastases identified early on or right at the initial diagnosis. And in order to understand these prognostic differences, we first looked at median overall survival. I'd like to call your attention to figure A over here, where the red line represents survival for the liver mets patients and the blue line represents survival for the lung patients. And as you can see, these two lines do not intersect, with the lung patients having a median overall survival of 2.1 years, which was statistically significantly longer than that for liver of 1.3 years. And then these trends were also seen in the resectable cohort, that's graph B at the bottom, and the advanced diagnosis cohort, that's graph C, where the median overall survival for lung mets continued to be statistically significantly longer than that of liver metastases. And these differences in median overall survival remained regardless of the type of first-line SOC therapy given. If you look at graphs A and B, graph A shows that if patients received first-line 5-FU-based therapies, the lung cohort continued to show a statistically significant longer median overall survival than the liver. And similarly, if patients received the first-line gemcitabine paclitaxel-based SOC therapy, lung was still statistically significantly longer median overall survival. And furthermore, within each cohort, whether you're looking within the liver-only cohort itself or within the lung-only cohort itself, be it a 5-FU-based therapy or a gemcitabine-based therapy, there was no statistical difference in median overall survival when you're looking within each cohort, pointing to the fact that the impact of chemotherapy is not driving these prognostic differences. There's something else at play over here. And we also looked at median progression-free survival. And while most of our results from median progression-free survival were not statistically significant, the same general trend of lung patients having better outcomes than liver mets patients remained. And actually, if I can call your attention to graph D at the bottom, we did have statistically significant differences in median progression-free survival for the lung cohort over there. So perhaps with more patients, we can have more statistically significant results even for progression-free survival as well. But collectively, these results are pointing to the fact that lung Mets diagnosis has more clinically favorable than a liver Mets diagnosis, has more favorable outcomes. And the last piece of our study was looking at the molecular signatures and really trying to see, is there a difference in which genes are enriched at which site? If you look at the red dots on this mutational frequency chart, there's 5 genes that were enriched, statistically more enriched within the liver cohort relative to the lung. These were TP53 mutations, MYC amplifications, CDK2A mutations, SMAD4 mutations, and mutations in the SWE/SNF pathway. On the flip side, for the isolated lung metastases, there was a completely different unique set of genes that were statistically more enriched in that population. These were CCND1 amplifications, GNS alterations, and STK11 mutations. So each group has its own unique set of enriched genes. So to conclude, patients with lung-only metastatic pancreatic cancer demonstrate a clinically and statistically significantly longer median overall survival when compared to patients with liver-only metastatic disease. And the response to a specific chemotherapy regimen does not explain these differences. Collectively, these results point to factors other than the impact of treatment on the prognostic differences between these two cohorts, namely the specific site of metastases. Liver-only metastatic PDAC was enriched for TP53 mutations, MYC amplifications, CDK2A inactivating alterations, and mutations in the SWE/SNF pathway and SMAD4 inactivating alterations. Now, these genes may impart a more aggressive disease characteristic to the tumor relative to lung-only disease because lung-only metastatic PDAC was enriched for a completely different set of genes, those being STK11 mutations, CCND1 amplifications, and GNS alterations. Now, this is whether this answers the question or not, it's just a small piece of the puzzle. We know that cancer origination and progression is a result of complex interactions between the tumor and its microenvironment. So integrating our data with future immunohistochemical, transcriptomic, and proteomic data can help pave the way in identifying patients at higher risk for metastases and therefore poor prognosis. But our data does support that site of metastases is an important prognostic variable, and it's something that should be considered as a stratification factor for clinical trials and included in the clinical decision-making process. I'd like to thank all the folks involved in this project from Cedars-Sinai, from Prothera, and our contributors from institutions across the US. And a special thank you to Dr. Arsen Osipov for introducing me to the study and for his continued mentorship and invaluable guidance in my research career. And thank you all for taking the time to listen to me today.
Fantastic. Okay, again, I'll ask all our speakers at the end of this session to come to the front so that if there's any questions from the audience, and we'll move on to our last paper. This is Dr. Yu from the Natural Science Foundation of China, who will be speaking on the paper Association of Non-Alcoholic Fatty Liver Disease with Pancreatic Cancer, a UK Biobank Prospective Cohort Study. Welcome.
So thank you, Dr. Cote, and aloha, everyone. It's really fantastic to be here in this slice of paradise. My name is Yu Jian, and I come all the way from Qingdao, China. Now, Qingdao is famous for its beautiful beaches and the world-renowned Qingdao beer, but I must say Hawaii has its own unique charm with that wonderful spirit of aloha that makes everyone feel at home. So this morning, Dr. Pendle shared some insights on the epidemiological association between diabetes and pancreatic cancer, and how beta cells and islet cells are altered, which inspired me a lot. And in fact, up to 70% diabetic patients have fatty liver disease. And now I'm excited to share this topic with you, the impact of fatty liver on pancreatic cancer. Sorry, which one? Sorry. Got it. So despite some improvement in overall survival rates over the past 30 years, the survival rate for metastatic pancreatic cancer is still around 3%. And in clinical practice, we see that more than half of pancreatic cancer patients develop liver metastasis, and nearly 2/3 of the few patients who can undergo surgery experience liver metastasis afterward. So during my PhD study at Hong Kong University, I focused on the pathogenesis and translational research of the metabolic dysfunction associated with steatotic liver disease. And the prevalence of MSLD has been increasing from 25% to 38% in the past 30 years. And although it has been reported to be associated with various cancers, including pancreatic cancer, the role of MSLD as a time-varying factor in revealing the risk of pancreatic cancer over time is unknown. So in the Cox proportional hazard model, a time-varying exposure means that the effect of a covariate on the risk of an event can change over time. And this is different from a traditional Cox model where the effect of a covariate is assumed to be constant over time. And for example, the impact of a treatment might be strong initially but weaken over time. And let's keep this in mind. So UK Biobank is the largest biobank of biological samples and genetic data, which enrolled over 500,000 participants. And over a median follow-up period of 14.5 years, we found that the incidence case in MSLD population was nearly as 4 times as those without fatty liver disease. So in this large cohort, individuals with MSLD had a significantly higher cumulative risk of developing pancreatic cancer and shorter survival compared to those without fatty liver. So in addition to a prospective cohort, we also utilized retrospective cohorts from multiple clinical centers to observe the progression of liver metastasis in the setting of MASLD. So we use non-contrast CT scans to screen for fatty liver, which we define as having a liver spleen density ratio of less than 1. Then we use contrast-enhanced CT scans to track how fast liver metastasis developed. And it turned out that patients with fatty liver had a much faster progression of liver metastasis. So what is the overall risk of pancreatic cancer in the setting of fatty liver disease? And the answer is around 3.5 in Model 3 after adjusting for various confounders. However, when MSLD is treated as a time-varying exposure, which we mentioned in the earlier slide, this risk became dramatically elevated, especially within the first 2 years after diagnosis, where it can be nearly 67 times greater. So it's quite surprising how much the timing of fatty liver can impact the risk. And very interestingly, MSLD appears to be a protective factor 8 years after diagnosis and potentially reducing the risk by nearly 2/3. And this could be due to lifestyle changes and medications such as an improved diet, increased physical activity, regular exercise, and treatments like GLP-1 and metformin. And these measures have also shown effectiveness in treating MASLD. So to sum up this part, our study underscores a notable association between MSLD and an increased risk of pancreatic cancer, and especially within the initial 2 years post-diagnosis. And considering that pancreatic cancer development spans over a decade from initial genetic mutations to a mature tumor, MSLD likely acts like an accelerator rather than a true risk factor during this period. And the potential timeline suggests a significant window for early detection and intervention. So we next ask how fatty liver shape tumors, thereby driving pancreatic cancer metastasis to the liver. And in current work, we focus on examining key molecules implicated in this process and assessing their translational significance. So due to time limit, I'm not able to walk you through mechanisms. So in brief, we want to address how fatty liver attracts tumor cells. So to identify key molecules, we utilize a publicly available database. and our own sequencing data. So first, we selected the single-cell database, which analyzed changes in individual liver cells across different stages of fatty liver. And specifically, we'll focus on genes whose expression increased with the severity of fatty liver. And next, we use another pancreatic cancer database to identify genes expressed in tumor cells. And we then performed a cell chat analysis by aligning these two genes, these selecting genes from two databases, and screen ligand receptors within with the strongest interaction. And finally, we filter the identified ligand combinations to include only membrane proteins or secreted proteins. This step is crucial for subsequent targeting and drug screening. So macrophage inhibitory factor was found to be one of the key liver-attracting signals in the setting of MASLD, which attract CD44 positive tumor cells to promote liver metastasis. And these results were followed by in vivo and in vitro validation. So I'll just directly go to directions so that our study highlights a pivotal role for MIF CD44 for driving metastasis in the context of fatty liver with increased cancer stemness, focal adhesion, and immune microenvironment reprogramming. And targeting this axis has shown translational significance and offers novel avenues for tailoring therapeutic strategies to individual patients with MASLD as an underlying condition. And most importantly, we are currently utilizing high-resolution spatial transcriptomic analysis on human liver metastasis samples, and we hope to share with our findings with you next year in San Diego. So finally, I would like to extend my heartfelt thanks to our basic and clinical research team, to all our collaborators and APA for giving us this opportunity to share our work in this beautiful season and delightful city. And our team leader, Professor Zheng, will share a topic on the mechanisms and translational research of early pancreatic cancer development with you tomorrow afternoon. And thank you again for listening. And if you have any questions, please feel free to ask.
Well, thank you very much. Great job to all of our speakers for these fantastic presentations. Again, in the interest of time, we will close this session, but I'll ask our speakers to come here to the front. And if anyone has any questions for them, please feel free to join us. Thank you.